you are free to attend this thing and you are free to leave at any point. And this is not compulsory. And this is different to all other learning activities in surgery. With all these curriculum-based learning activities, we felt that students are really afraid of surgery. To make you more familiarized with surgery, we thought a different approach may help. It may not help as well. So it is important to sort of give us your feedback to improve this or to eliminate this altogether if it's not going to work. So this may involve many activities, for example, and we may add some more activities as well. This activity is based on common surgical problems. Right? We will discuss some common surgical problems. So there is no syllabus. We are not sort of bound to cover number of surgical procedures, but common surgical problems we discuss with its relevant anatomy, physiology, pathology mainly. If there is any other specialty involved in it, like microbiology in surgical infections, or pharmacology, different types of probably inflammatory bowel disease management, we will discuss those things as well. So incorporation of your basic science, and we pay more attention to the basic science rather than surgical procedures, techniques during this learning activity. And we hope, in addition to this, we will talk about ethics in surgery, learning techniques in surgery, and anything else, Rohan? This is also very informative.
Yeah, and also I think
assessment in surgery
and how to answer question, how to face a viva.
Yeah,
we thought of different, but you can also suggest that
yeah.
This is what we think, but what we think is not very important.
Yeah.
What is important is what you think
and what you dress and all these things.
Yeah.
How you eat and what you eat and how you maintain your body image. All these things may matter. So when you suggest, we can improve on it. Right? So today's discussion topic will be.
And one thing is, as we go on, like if there are any questions, you can ask. But if you are afraid to ask, probably you can type it up in the chat box.
Of course. Yeah. This is not formal, so there is nothing going to your grade or marks or anything, right? So don't worry, don't be afraid. You can sort of ask questions at any point. You can disturb us at any point. So today we are going to talk on hernia. Hernia is a common surgical problem, right? And there are different types of hernia. So before talking about different types, I'll tell you what hernia is. Now, personally, I don't sort of expect you to by heart definitions of certain things, but anyway, that is my personal view. No, most of the time in exams, you may have, whether you like it or not. There are certain things in our life you have to do. Why I don't like it, why I don't encourage that is no definition is 100% accurate in explaining all clinical conditions. So like that, so commonly used definition for hernia is protrusion. It is an abnormal thing. Hernia is not a physiological or normal thing. So it's an abnormal protrusion of contents of a viscera through its wall, right? So it is an abnormal thing, we know, and it is protrusion, and this protrusion occurs through the wall, which is weakened, right? If I push my tongue against the cheek, that will protrude my cheek, but that is not an abnormal protrusion, and that is not weak wall also. But having said that, there are hernias Now, for example, hiatus hernia. There is no abdominal wall through which it protrudes. So there are exceptions for this definition even. That's why I said sort of definition can't explain everything. But as a first learning event, we usually define certain things. Okay, so definition didn't come before hernias are recognized. So all these sort of definitions comes after hernias are recognized. Okay, so hernia is not a one clinical problem. It is sort of, you can get many hernias, and for easy learning, we classify these things in different ways, right? There are hernias through the abdominal wall. Those are the commonest types of hernia. Even through the abdominal wall, you get many hernia. You get inguinal hernia, you get femoral hernia, you get obturator hernia, right? So different types of hernia like that. You can get internal hernias also. Your brain also can herniate through the what is that type? Foramen magnum.
So can you say if anything that passes through the abdominal opening can it be a hernia? Is it now when we talk about hernias, it comes to our mind, okay, you are talking about something inside a visceral cavity, either thoracic cavity or abdominal cavity, and that's covering. The typical definition is cavity covering membrane, something protruding through the wall.
Yeah.
So actually, that does not accommodate all the hernias.
Yes. Hiatus hernia doesn't go through any.
So hernia is something that protrudes.
Yeah. So it protrudes.
But everything that protrudes does not mean a hernia.
If I put my tongue out, it's not a hernia.
So it's abdominal protrusion.
Yeah.
So any abdominal protrusion to a defect is a hernia.
Even without a defect, is a hernia.
So it becomes it's not simple as that. So I'm trying to point out is the definition of hernia is not as simple as that. Even though you try to memorize it, okay, this is a hernia, but that does not really explain all the hernia.
That is why I personally believe in definitions, because definitions come after you discovering
the condition. You try to accommodate the definition, but you can't accommodate the definition.
But a similar thing. Yeah. We are happy to have dean of the faculty with us today.
Pathologist. I'm here as a pathologist, not as the dean. Okay.
So we were talking about hernia.
Yes, in
formal way, we were arguing about sort of how appropriate the definition of hernia.
Right.
So we get sort of more commonly, we get anterior abdominal wall hernia. I think sort of different types of hernia basically depend on the site which it occurs. But the mode it occurs also classify these hernias, incisional hernia. That is due to the etiology or the cause which leads to this hernia. Then what do we expect from a medical student or a junior medical officer when they get a patient with hernia? Mandir Rohan, now the clinical problems, now certain clinical problems you have to diagnose. Now hernia is a peculiar thing. Most of the time, 90% of the time, patient come with the diagnosis, especially in groin hernia.
But sometimes it's not
accurate.
And also sometimes they may not come with the hernia, especially let's say someone comes with a groin pain.
Yeah.
Sometimes you actually find the hernia when you examine.
Yes.
So it can be the presentation may actually not be a hernia presentation. You might come with something else, and you find when you examine it's a hernia.
Yeah. But most of the time, the patient's diagnosis is correct in case of hernia. Things like hemorrhoids. Patient most of the time come and tell you he's having ulcers, but 50% of the time the diagnosis is not correct. So this is the beauty of this clinical practice, right? what should you believe and what should you not believe. That doesn't mean patient is lying.
Should you expect a student to go beyond, not student, a primary doctor to go beyond just saying it's a hernia, like for example, classify the hernia as if it's inguinal as direct, indirect,
Yeah.
or whether it's reducible, irreducible?
That's what I'm trying to tell them, because even patient knows that it is a hernia. Now, if a medical student at the end of the examination also tell it is a hernia, that's not much of a difference. So we expect more from them, and we expect them to make their diagnosis based on evidence. The patient doesn't make the diagnosis based on any evidence. So he should make this diagnosis based on clinical evidence. Clinical evidence means history and examination. Right? In fact, there are radiological evidence of hernia as well, but more than 95% of the hernias we diagnose based on history and examination. You agree with me?
Yes. So, let me tell, okay, what exactly the questions that you need to answer after the examination or your assessment.
Now, the peculiar clinical feature of hernia, if you take as a lump, if they feel a lump. This particular lump is reducible. Right?
So, key feature what you're saying is key feature of a hernia is reducible.
Yes, if at least in its beginning, there may be irreducible hernia, but at the inception, it was a reducible. And there are some reducible lumps as well. Now, vascular lumps are also reduced. Some lumps are compressible. Now, reducible lumps and compressible lumps are two different. But this lump, you can make it prominent also by certain maneuvers. Now, abdominal hernias, anterior abdominal wall hernias, you can make them prominent by coughing or increasing intra-abdominal pressure. So the reducibility and so can make them more prominent by certain maneuvers are can't say pathognomic, but key features of a hernia. Anything else to promote?
I think as a medical student or a doctor, when you approach the examination of a hernia, the anatomical location plays a big role. Because when we are talking about a short case, for example, if the lump is at the umbilical region or inguinal region, our approach is completely different as opposed to if you see a lump in the over the deltoid, right? So you approach it as a hernia, or the first thing we would do is cough and see the coughing parts. So I think about 90% of the hernias, the anatomical region plays a big role because we know that umbilical region it's a PUH, inguinal hernias, abdominal wall hernias. If it's related to incision, it's an incisional hernia. The femoral region, it's femoral. So I think 90% of the time, it's based on the anatomical location that we say. So this is some sort of a hernia. And I think as medical professionals, we should get away from using this plain and simple word of hernia because all patients say it's hernia. So we should at least, at the first instance, qualify inguinal hernia or paraumbilical hernia or abdominal wall hernia, something like that. Because it gives a completely different hernia can be used as a noun and then herniation is a verb. So it's very confusing. So when you are talking, don't ever say as a medical professional the patient has a hernia. I think you should say patient has an inguinal hernia or incisional hernia or anterior abdominal wall hernia and so on. And this anatomical location plays a huge role in your approach because we won't ask a patient to cough if you have a lump in the chest, right? It can be rarely to fall into the category of hernia, but first thing we do is not that. And if you see a PUH or an umbilical lump, we don't take the same approach as you examine a sebaceous cyst to see the plane of the skin or anything as such. So it's very important, the anatomical side.
Can we discussed quite a lot. Can I just say we discussed, came to 2 points.
Yeah.
One is, we said that it's important that you do a clinical diagnosis to the hernia. So you examine the cough impulse.
So there should be evidence-based.
Evidence-based. You give a clinical diagnosis.
Not just because patient say he's having a hernia.
Yeah, it's a hernia based on your clinical results. That's the first requirement. Second, the promote said we should also give an anatomical diagnosis for the hernia as well, depending on the region. So that is what the main topic is discussing there. Anatomy, but should we give a pathological diagnosis also? Is it important?
Yes, they come next.
Yeah.
Now, so just saying now he's having inguinal hernia, femoral hernia on the right side is not enough, I think. We expect more than that from a junior physician. Right? So when you encounter hernia, the other important thing is we should know. So usually in the textbook they say the risk factors for the hernia. But when a patient comes with a hernia, alteration of these risk factors is not going to sort out their problem. If patient is smoking, stopping smoking is not going. It's not the treatment for the hernia. So the more important thing of the risk factors is those are risk factors for recurrence. So if you don't address those risk factors, they may get hernia again even after successful treatment. So it is okay as a junior medical officer to say risk factors, but I would rather happy if they say they are risk factors for recurrence. So we should be able to recognize whether this patient has got any risk factors for recurrence. So it's a bit of a homework. Go and find out risk factors for recurrence.
That's a list of things that you can read.
Right? So definitely, if you get a hernia, these are the questions we ask, and these are the questions you should ask from the patient also to recognize whether he has got any risk factor for recurrence. Textbook will not tell you sort of risk factors for recurrence, so they will say risk factors for hernia. Right. So other thing is sort of now most of these hernias, at least in its initial stage, is reducible. But once when these hernias are there for some time, they tend to get problems, or we call it complications. Right? So you should be able to recognize any existing complication, or you should be able to recognize any impending complications, which are the complications which may occur in this patient in near future. Right? Certain body habitus, certain types of hernia are associated with higher incidence of certain complications of hernia. Mainly complications of hernia are irreducibility, obstruction, strangulation, right? And strangulation related problems. Now when we talk about irreducibility, now all strangulated hernia, obstructed hernia are also irreducible. When there is a complication, any complication also, when we talk about these main complications of the hernia, they are irreducible. But even without strangulation and obstruction, you can have irreducible hernia. And I said sort of irreducible hernia are likely to get other complications more common. Obstruction of a hernia is an important technical term which you should understand. Obstruction means it's a bowel obstruction, it's nothing else. Right? So if the hernia contains omentum, you won't get obstruction. Right? We call this obstruction for the bowel, not for any other contents of the hernia. And strangulation is a problem of the bowel, as well as you can get sort of other structure as well. Omentum also can get strangulation.
Is it a strangulation is a pathology term that is used in pathology, madam, or is it a?
No, it's a clinical term. Strangulation means the blood supply is impaired, right? So strangulation can occur in any of the hernial contents. I think I'm loud enough for you all. But obstruction, and I think you were trying to make that point. Irreducibility, obstruction, strangulation are three different terms, but can coexist in different situations. Obstruction means that the bowel is obstructed, but it may not be strangulated because the vascular supply may not be impaired at that point. Strangulation can occur without obstruction if other contents of the hernia sac are within the hernia, like for example, omental tissue or very rarely ovary or fallopian tubes in a female, that kind of thing. So obstruction and strangulation does not always have to be present. That's a very, very important aspect. I just want to ask you a question. What's the difference between incarceration and irreducibility? That's what I
The first time I learned about incarceration was when I read about Napoleon was incarcerated.
Yes. Prison, in prison, meaning again.
So that is the thing which is in my mind. So incarceration, incarcerated hernia is also irreducible.
Exactly.
Because the contents of the hernia are adherent to the sac. But it is not obstructed, it is not strangulated. As there are adhesions between the contents and the sac, they can't escape back into the stomach, abdominal cavity.
Obstructed and strangulated hernias are also irreducible.
Yeah. That's right. All complicated hernias are irreducible, but you can get irreducible hernia without obstruction and I think that is important. If we emphasize this fact over and over again, and it is important now to recognize these things.
So when for example, a student sees a short case of a hernia, wouldn't you expect them, from what we have been discussing so far, to give the size of the hernia, the type of hernia, whether it's inguinal, or whatever, and the fact that whether it's reducible, irreducible, obstructed or
hernia. But we may ask, right, what are the possible complications of a
But
irreducible?
isn't it nice that when they give the diagnosis, they have given the entire diagnosis, leaving you nothing to
The
ask?
purpose for that,
Good students might be doing that.
purpose for that short case is at the end of, now let's say he or she passes out and you see a patient in the clinic and you assess and you present the case to your consultant. By the time that you present to the consultant, you found the consultant, I should be able to make a decision on this hernia. So if the person gives me enough information, okay, this is right side or left side, we have got indirect hernia, and whether it is complicated or uncomplicated, and whether he has these factors or not. Those are the information that I need to decide on this patient. So if you can give that, that is what is expected in the short case. And if you do that, you get your marks.
We have this very famous teacher of ours, who must have taught you all, I don't know. Hello.
Dr. Andre Fernando is joining with us now. He's a senior surgeon.
Professor Devi used to say, you must give answers so that the examiner has nothing more to ask you. Right? Then you are taken to another level of questioning, like for example, what kind of repair would you do on this patient? Right? Otherwise, he used to say, the patient say hernia. Right? What side? Right side, sir. What type of hernia? Irreducible, sir. So you each answer you take like you milk out of the student. Don't let it come to that. Be very confident. Tell your surgeon this is what
And the purpose of that answer is so that I can make a decision.
Absolutely.
And also, you don't expect great detail as well. They can say whether it's complicated or uncomplicated. That could be enough. So you should know what a complicated one is and what is uncomplicated. As we said, simply incarceration might not fall into a complicated hernia. You need to operate right then and there. And also, sir, I think in today's context, when you're talking about a short case, but you're talking about hernia in general, whether it's symptomatic or asymptomatic is also another point that we need to address.
Two important points from both ways. One thing is complicated or uncomplicated hernia. Again, now uncomplicated hernias are reducible hernias, which doesn't have significant impact on his day-to-day life. So you can ask only two questions. We can look at mother. So if you ask those two questions, we know that sort of you are hunting or you are trying to extract this fact from the patient. And the other thing is again, symptomatic or not. We will come at the end, or what we do is sort of asymptomatic hernia. What are we going to do? Right.
The things are, is it really important for student to clarify that it's indirect or direct? Because from surgical point of view,
Yes. Now, there is no clinical value. Now, for me, whether it is a direct hernia or indirect hernia, the management is the same.
Yes.
But most of the examiners, you have to face different types of examiners. That is the reality. They are very fond of knowing whether it is direct hernia or indirect hernia. And the truth is, it is 50% of the time it is incorrect. It is a fact which is not that relevant, and it is a fact which is 50% times incorrect clinically, when you assess clinically, but they want to do it. So you have to somehow prepare your mind and do it.
And
We were brought up in that era.
Maybe now with the advent of this tensionless pre-peritoneal repair, there is a mesh which is covering indirect ring, direct space,
And even
everything.
the femoral.
Yeah. In fact, the other thing is now, even though we clinically this is indirect, there may be some combination complicated type of hernia as well. So maybe smooth had been bold enough to say it. Yeah.
So am I.
Yeah. So it is not relevant. I never press on student direct.
But I have seen exam.
But
Yeah,
some examiners do.
This is
So students should also know that.
Yes. Yeah.
Alright. Now, when you go to a temple, whether you like it or not, you have to take your hat off
Yes.
and remove your shoes
Yeah.
and go in.
For that reason also, because otherwise, if students get away, this is our young people, they have to face with an examiner. What is it? We viral point, we point of the viral ligaments, all this question. So better to be, but in the earlier management, I don't think there is any important.
Other thing, some examiners would like to know, why do you want to know this? Now, I said certainly this is not relevant to me. And Andre and Rohan also agree with me. Probably you do. But still, if the examiner says what is the importance of knowing this thing, what he wants to know is indirect hernias are more liable to get complications. Right? Whether you like it or not, there are certain things you have to buy hard. Namaskar, Dumparak
Okay, I just want another question about strangulation. Now, if you look at a specimen of bowel that you get after strangulation, is it, you see more necrosis or more congestion, or because what happens is venous, it's not arterial insufficiency that you get first.
Yes, venous insufficiency.
Yes.
That's right.
So, what will you see if you look at bowel? That's okay.
So what do you mean? In the early stages, what you see is a very reddish, ecchymotic kind of bowel.
That is macroscopically.
Macroscopical, right? With
So bluish.
No, first it's very reddish, more reddish than bluish. But with time, when the venous insufficiency remains, it becomes more blue. And the dark, black, green appearance is your typical gangrenous bowel. And that when you touch and all, it feels more friable and very foul smelling, the luster is gone. Having said that, I must say that about 7 or 8 times out of 10, what the surgeons remove and send us as gangrenous bowel still show only mucosal necrosis, right? Not transmural total infarction.
So ischemia is initially felt or worstly felt in the mucosa.
Yes.
You mean sort of hypoxia is felt mostly in the mucosa
Mucosa.
rather than the wall.
Entire wall,
Good density.
right? And then also, when the mucosa is affected, we can still leave it because the mucosa is made out of labile cells, if you remember your pathology, and therefore you can have complete resolution, right? But of course, that's why it's very difficult for you all to make that decision based on the color and the bowel. So in that sense, it's better to be safe than sorry to excise that bowel and push it back rather than have a non-viable bowel going in and perforating at a later stage. Ne?
Now, this is not in hernia, but now most of the time, what you said is absolutely correct. When you come across patients with ischemic bowel, when you do endoscopy, we see slough of mucosa, very entry-looking slough of mucosa. We think it's ischemic bowel, and when they open up, the outside is quite normal. Right? But in bowel, the strangulated hernia, of course, when you open up, what we see is ischemic bowel wall. So we think definitely mucosa should have wall in this patient. Do you see when the wall is ischemic and mucosa is intact?
Generally.
Unlikely, isn't it?
Unless you have a strangulation where it's involving only part of the bowel, where the entire bowel is not obstructed.
It's just type of hernia.
Irish.
That is another type of hernia, madam highlighted. Go and read about it. RICHTER.
Once we resect bowel, now after we resect, anyway there's going to be skipping changes in the bowel. How do you differentiate whether it happened after we resected or is there a...
You mean between the clams?
No.
Set the specimen. It's
Once we
anyway-
set the specimen, anyway there's going to be some ischemia element in the...
What he says is when we remove the bowel, it is anyway ischemic. No, it doesn't have that.
No.
So
We
when
put
this
it into formalin immediately, no.
You have
Okay.
In case you don't, please start putting into formalin. So that won't happen. That is autolysis.
But when you put formalin, most of the time we put two clamps. Let's say we without opening up the bowel, we send the specimen with two clamp ends so that you have gas inside and formalin outside. The formalin does not go inside.
It
Will
will
that be effect?
penetrate. No, it will penetrate.
Yeah.
Generally, but it's good not to have the suture ends, to keep the ends open. Or at least if you can keep one end open and shove a bit of gauze or something into it, then
That's
it
the
will
better way of
penetrate.
preservation.
Yes, because otherwise, as you know, the pancreas and the bowel autolyze very fast. They have their own commensals and their soft tissue. So it's good to say.
So far we discussed it's important to recognize hernia on evidence base. That is clinical evidence, history and examination. Two important things in the history and examination are reducibility and become prominent maneuvers which increase intra-abdominal pressure. Then you could be able to recognize the type of hernia, right, and assess any risk factors for recurrence. Then the existing or impending complications. Here, the important complications are irreducibility or incarceration, strangulation, and obstruction. Then the things like inguinal hernia, femoral hernia, where they are now this anatomical site is duplicated in the body. Right? So it is important to compare the opposite side. Right? Is there a genetic predisposition for hernia?
Yes.
There's a
Yes.
Yeah.
Yes.
If you have bilateral hernias, I think the childhood, sometimes they have the continuous margin defect.
That's actually the problem with the pathological problem.
Especially in males. So it is a good idea to examine the other side as well. Right? So what they say commonly is if they are paired, do compare.
And also if you have this sort of a deficiency, congenital deficiency, you are more prone to get things like aortic aneurysms as well. There is a
Collagen
correlation.
Yeah, mucopolysaccharide.
So-
the anatomy, sir. Pathological.
No, it's okay. It's interesting to me also, right?
Then, we are not going to talk on types of treatment here, but it's a mainstay of treatment is surgery.
We discussed that point in detail during last discussion whether you can manage conservatively.
Yeah.
Yes.
And the mainstay of treatment is surgery, and you should know about post-operative complications as well, right? The bare core knowledge is highlighted in number 3. This is the evidence-based diagnosis, assessment of risk factors for recurrence, existing or impending complication, and compare the opposites.
Can I ask you questions now? Assessing risk factors for recurrence. What are we talking about? You have seen a lot of students asking,
Now there is no evidence, but most examiners also want this answer. That's why I am going to tell that. But it is not an evidence-based thing. Weightlifting carries the risk factor for recurrent hernia or even to get a hernia. But if you knowing that, if you say it is, it's okay. I suppose.
Usually after repair, I usually advise patients not to exert for about 6 weeks. 6 weeks. And after that,
Idea of that, I think, again, wound healing. I would like to
basically-
a brief to tell us why it is 6 weeks, even for other type of wound.
So basically, wound healing, there are like three phases of wound healing. The first phase is the inflammatory phase, where you get inflammatory cells like polymorphs and macrophages coming in, taking away the debris and clearing that area. That's about 3-4 days. Then we go into the proliferative phase, where fibroblasts turn into what are called myofibroblasts and start laying down collagen. And at this point, the collagen that is laid down is the type 3 collagen, which is not high in tensile strength. And over the next 6 weeks to months, a couple of 4 to 6 weeks and above, you get it being converted to type 1 collagen, which is your scar tissue, and that is probably the reason behind Dr. Pramod advising his patients to stay a bit safe till that time. Because after that, you get almost 80 to 90% of the normal tissue strength. And so that's why it's important to know about.
So the repair is with fibrous tissue. It is not a replacement of normal tissue.
Repair is fibrous tissue replacement, right? And also at that point, if I remind you of your pathology lectures again, there are a lot of cells that are important, macrophages, which produce what are called cytokines and growth factors. Very important in your repair process. These growth factors like fibroblast growth factor, vascular endothelial growth factor, transforming growth factor beta, and interleukins. All these help in producing collagen as well as remodeling, as well as angiogenesis, as well as granulation tissue formation. All that I would seriously suggest that you go and buy your pathology notes back from the, have you all sold them now? Not yet, no? If you have, please get them back. Now, these are questions that are quite important in surgery.
Understanding.
I think this is how you should learn medicine. When you learn the basic sciences, you come and ask, why are we learning this? And when you learn the clinical sciences, you go back and remind, this is why we learned that in the past. So you do it vice versa.
This is actually based on a fact.
You go around to your surgery ward, and every student will teach you some pathology. Every patient will teach you some pathology. Right?
So this highlights the importance of basic anatomy and at least pathology today, right? Understanding, recognizing complications as well as treating. All the treatment is behind sort of pathology, right? The principles of treatment based on the pathology of the tissue repair. Then, shall we go down? Let's watch now. I said sort of the mainstay of treatment is surgery. And for understanding sort of what we do in surgery, you should understand. We'll talk about. We'll take inguinal hernia as an example and talk about hernia from now onwards. Alright. Prasad, can you highlight?
Sir, shall we first put the video and then we show what we see and we try to explain?
Yeah, correct.
Right. Shall we watch a video of sort of hernia? Now, this is a laparoscopic hernia repair, right? So the laparoscopic hernia repair usually needs general anesthesia, but most of the time hernias are repaired under local anesthetics or spinal anesthetics. I'm telling inguinal hernia, but laparoscopic hernia repair needs general anesthesia. So this is
I think best person will let.
yeah. Anterior abdominal wall. How do you see it from inside?
Inside, yeah.
Yeah.
Yeah, we teach the students about these the folds. These are common, very famous spots test for them also. I mean, median umbilical, specimens. We have
peritoneal fold.
Peritoneal fold. These 4 folds: the median umbilical fold, medial umbilical, and the lateral umbilical fold. And we ask them what are the structures or the embryological structures that are underlying these.
Okay, but there is now a bit confusing. You said medial umbilical fold, median umbilical fold, and lateral umbilical fold. Which is in the center? Median or medial?
Median. Median means the median.
Median, that's center.
Right. So it is connected to the bladder.
Bladder, yeah. Because embryologically it has a urachus. The urachus goes to the umbilicus. So that it connects this anti-abdominal wall, the bladder, the tip of the bladder, it connects to this umbilicus. So that's a median
it is
umbilical.
obliterated.
Obliterated and it's not functioning.
Is the continuation of that is the falciform ligament?
Yeah,
Yes.
above one, yeah. Yes. Yeah. That's the ligament. That has this the obliterated vein.
Which way?
Umbilical vein. Only one umbilical vein. Two umbilical.
So what is medial umbilical ligament?
Medial umbilical ligament has this this thing is there, the umbilical ligament and the fetal umbilical artery. There are 2 arteries joining goes into the umbilical cord, and only one umbilical vein. That is why I showed in the falciform ligament has only one umbilical vein. These are obliterated and it's not functioning.
So these umbilical arteries are also obliterated in adults. Right. Then the
Lateral fold, you get these vessels. These carry these inferior epigastric artery and the vein.
So that is the most important landmark for us.
Yes.
Right.
That too, we are not
We are not worried that.
That we cannot safely.
As you mentioning about this peritoneal folds, now what are other peritoneal folds we see in that domain? Maybe them are there. They are not here. Now, okay, we'll go for that slide. Now, this is from inside. This is a real picture from inside.
So
We
they
have one
identify all those pores every time you open it.
Yes, so the video I think we should be able to see better.
Yeah, a video. Alright. Right. This is a video of left side of the lower anterior abdomen. You can see a big hole. It's not a black hole. Right. So that is a hernia. You can see a defect, but that is a weakness in the wall through which the peritoneum has creeped inside. So this defect now, this is on the left side. If I say it is medial to the lateral umbilical fold, which
That's
contains
inferior
inferior epigastric vessels, artery and the veins. And you see sort of further laterally, just lateral to that, you see the vas deferens which is coming down, and the gonadal vessels with lot of imagination you can see, I suppose. I think because it is covered with the peritoneum, right? Once the peritoneum is removed, you can see very well in the gonadal vessels. But vas deferens is whitish and sort of you can see it is coming down. So the lateral to that, the point where these things enter is the deep inguinal ring.
So that is, we are looking at the deep inguinal ring from this side.
Yes, this is the appearance of deep inguinal ring from the inside. As there is no indirect inguinal hernia, you don't see any defect here, right? The structures entering here, you see vas deferens going there, gonadal vessels going there, right? So they go medially from there, right? In a tunnel in the anterior abdominal wall, which is called inguinal canal. Prasad, can you sort of explain about inguinal canal, the way medical students are more familiar with?
You have outside pictures.
No, I think I can do this. I think that what we always say, why we get this in canal? Because we have testis, and the testis needs the temperature, lower temperature for this spermatogenesis. So it has to be outside the body cavity. So that because this testis develops in the posterior abdominal wall and the genital ridge, so that it descends downwards, and there is a pathway that it traverses from the internal inside the abdominal cavity to the external side. So this is the tunnel. So
Carrying its blood vessels
processes also, and all the tubes. So
why the ovary doesn't sort of descend down?
yeah, the thing is that what I think that ovary doesn't need this temperature problem. So
Ovaries can adapt to any situation.
So for the hormone production now, the testes has a spermatogenesis as well as testosterone. So for hormone function, you don't need a temperature issue.
Yeah.
Right? That is why even sort of undescended testes, they develop sort of their secondary sexual characteristics, but they don't have spermatogenesis.
Prasad, is there an anatomical reason now? If you look at the pathway of descending of the testis, actually it is taking a long path.
Yeah.
Rather than taking a shorter path, you can straight away go into the straight.
Yeah, because
is there an anatomical reason for
yeah,
that?
that is to create the valve-like effect, because to close. Otherwise, the defect, if you have a approximation of these two ends, there will be a greater defect, and the things can go in easily.
So this is a S-shaped.
Okay. So there is a reason for
Find the difficult way of doing
No, in children, the deep and superficial veins are overlapping. When they grow, sort of it become a part. External developing. Have you got it?
Yeah.
Because students appreciate the fact that this hole is not the deep inguinal ring, but it's a defect of the posterior.
Okay, second line, third line.
Why?
This is the thing. Now this is from outside, but we have removed the skin.
Yeah, skin. So you can see the femoral arteries and all these, the inferior epigastric arteries going.
From where does this inferior epigastric artery come, sir, Prasad?
Is it from the abdomen or the femoral?
Pardon?
It's from the abdomen, but what do you think? You must have seen this.
Yeah. From where does it come?
It should come from the abdomen, right? That is the common IX.
So it comes from the common iliac artery, external
External
iliac artery. So the continuation of that is the
The
femoral artery.
When
Right?
it
So you
passes,
see the femoral artery here, right? Beyond that, above that, what
that
we
is
see
the
above is the
external
external
iliac
iliac artery. So it gives the inferior epigastric vessels.
So,
Right? So inferior epigastric vessels, the lateral to that, you get the deep ring, and here you get the superficial ring. So between that, in the anterior abdominal wall, you get the inguinal canal.
Oblique canal.
So what are the, now you said sort of it has the contents to survive testes, right? So
the spermatic cord,
Yeah.
and its blood supply and the nerves.
What are the nerves inside the inguinal canal?
There are 3 nerves. What are those? That supplies this genitofemoral nerve, genital branch of the genitofemoral nerve. Then the ilioinguinal nerve, and the nerve that supplies this penostric muscle.
Right. So those 3 nerves are within the inguinal canal. But iliohypogastric nerve is not in the inguinal canal.
No.
Right. Common MCQ they used to ask from us. Those days.
This is a common thing that we ask in the spot test.
So those are the contents of the
Somebody
inguinal
has
canal.
raised a hand.
So during surgery, we see only one nerve.
Most of the time we don't see.
Here you don't take the spermatic cord.
Yes.
The rest of the other nerves are inside the spermatic cord.
That because of we see only the ilioinguinal nerve.
That is only because that is outside.
Outside the
outside.
yeah.
That is why you don't see the other nerves.
So is the ilioinguinal nerve is motor or sensory?
Ilioinguinal nerve.
Or mixed nerve?
Mixed nerve.
So if you damage ilioinguinal nerve, which happens most of the time during hernia surgery,
But sometimes you
deliberately, yeah.
If I can preserve, I will preserve. Otherwise, I will purposely cut.
The reason why now some people now it is not a good idea to cut an anatomical structure which is sort of yeah, not a name. And not like cutaneous nerve, it doesn't have a specific name. The reason why some people divide it, so it's because if you divide it from the root, the chances of forming a neuroma is less and causing pain is less. Right? Otherwise, sort of if you accidentally damage with the diatony, right? They tend to get pain. Whether you cut deliberately or accidentally, most of them complain of numbness.
Yeah, numbness. Yeah.
What exactly is the area that is supplied by the ilioinguinal nerve?
Ilioinguinal nerve should be supplying the area in the just above the thigh and this area.
In
Right?
aspect
In
of
aspect
the
of thigh.
upper thigh.
That's it.
But there is not a overlap with other nerves.
Yeah, so that
That
you
is
don't
why
get, so much
most of them will not appreciate this thing. At least sort of with time, they get adapted to it. So one complication of hernia surgery is sort of there's a numbness in the upper thigh. So most of the complications of surgery are related to the steps of the surgery. If you know anatomy and the steps of the surgery, you can recognize early complications. Let's go back. Yeah. Now let's see the video of sort of laparoscopic hernia repair. Now repair and herniatomy are we going to discuss on?
So almost there.
Treatment.
Normally, some of them they are having a queue at 1 o'clock. We will continue for once who was saying about 8 people were there.
Yeah. They can open.
They can record. So we will take another 20 minutes.
Video 10 minutes edited video. You see the bladder and the median umbilical ligament.
Which one is median?
Right?
So that's a lateral umbilical.
This is right.
This is a median.
This is the median umbilical ligament. Median, right?
Median.
Mathematical. Right?
That's a hernia that you see in the big thing.
It's a direct hernia. Right?
So it's coming through.
It's medial to the
Medial to
epithelial
the
gastric
gastric
acid.
acid. So that is
Right, yeah. So,
Actually, treatment is not different whether it's medial or lateral to the gastric.
yeah, it takes a large measure covering everything.
so actually you can explain the hernia by looking from inside rather than looking from outside.
Yes,
Yes.
yes,
Inside, it's very obvious.
and very easy also. Even a subtle hernia can be recognized from inside. Okay, so we are dividing the peritoneum.
So why now? What is the basic expectation here? First step. What is your way? What are you trying to achieve? This during this step.
Yeah.
What are you trying to achieve?
Now we don't see any contents.
Yeah.
What you see obviously is the sac of the hernia is a peritoneum. So the first step is to reduce the peritoneal sac back into its normal position.
I think even during open surgery, it's the same. I mean, it's
Yeah,
same
yeah.
step.
It is open or laparoscopic.
Yeah.
The basic the concept or objective is the same, right?
So that's the peritoneum that you see.
I'm holding the peritoneum, right? And we use the diathermy. One day we'll talk about this, what diathermy is. It uses electric energy to divide tissues.
So peritoneum is a distinct layer that you can separate. You separately identify.
Yes, yes.
It's a single cell layer. So it's
Peritoneum.
Yeah.
The covering is single. Yeah, it's zero. But what you get is you get a little bit of that.
I divide peritoneum without any bleeding. How does the peritoneum get its nutrition matter?
From the posterior abdominal wall, if it's the posterior.
So it's by diffusion.
No,
There are tiny vessels. Small.
Now you see some white line, right? That is, what is it? Right? It is not a sac. I am holding the peritoneal sac, right? That is the weak posterior wall, right? So that is transvalis fascia. Right? So what is transvalis fascia? In fact, we know external oblique, internal oblique. What is this transvalis fascia?
Transvalis fascia is the inside this, just deep the peritoneum.
Yeah.
You get these tissues and thickened area, and then it's the like I think there's a fascial layer.
Yeah. So the weakness of transvalis fascia through which sort of this has come.
Yeah.
This is a direct hernia. Direct hernia has come through that.
Yeah.
That forms the flow of the inguinal canal.
Now,
So students should know sort of different walls of the inguinal canal and the structures which construct those walls.
can we explain that?
So now we have sort of separated the peritoneal sac from the transvalis fascia. Moment I separated it, it's back to the normal. Right? Now what you see is the pubic tubercle and the iliopubic. I'm going towards the iliopubic tract. Right? Taking little tissues and with the diathermy. That is in inferior gastric vessels. Little careful at that place, right? But if I damage it, sort of, I can afford to ligate it.
Yeah, because it is the
So why is it important for a medical student or a student to know the basic steps? Now these are we strip the peritoneum, we separate the transversalis fascia, and then we now we are dissecting on the inferior gastric artery, defining the border. So why is it important for someone to know the steps?
Steps. One thing is now all the complications, most of the complications are related to these steps. Now, if you damage the inferior gastric artery, it causes primary bleeding.
So if you do a laparoscopic hernia, if someone bleeds, you are suspecting the bleeding.
That is the main cause. Right? If it's a significant bleed, it is damage to the inferior gastric vessels.
And we have done laparoscopy.
Yes.
Have you ever experienced bleeding from inferior gastric? Lot of patients.
That is because they take enough precautions there. Right?
So you expect this can happen during this step,
Yes.
and then you take precautions to prevent that.
And this can happen in open surgery as well. Open surgery, we don't see this.
Okay. Now this.
And other thing is sort of there are important nerves, right? Not only this, there are some vessels behind or deeper to this, like femoral vessels, femoral vein. We don't see it now, right? common iliac become
Under the.
under the inguinal canal, external iliac. External iliac vessels become femoral vessels, right? So that is the triangle he called is triangle of doom, right? You see the vas deferens. So we know that place and we are not dissecting to the femoral vein, right? If you go there, if you use a diathermy, with a single activation, the femoral vein can get damaged. External iliac. External iliac vein, the continuation is beyond the inguinal canal is the ilioinguinal ligament is the femoral vein. So it is called triangle of doom, and you get a lot of nerves lateral to the this triangle, right? Those are iliohypogastric nerve, even the ilioinguinal nerve, right? So if you damage those nerves, usually you don't see these nerves during surgery unless it's very deep, right? You probably may see it, but we don't see these nerves. But we know that those nerves are there, right? So we don't meddle too much with diathermy in this area. And we don't apply any cleat stackers in this area because it can cause pain, chronic pain. Now you see the vas deferens, right? So now when you get inguinal hernia, the indirect inguinal sac, the most intimate structure to the indirect inguinal sac is the vas deferens. So rather than dissecting the sac, what we do is we separate the sac of the contents, right? If you separate it virtually from the vas deferens, you are there. Now you can nicely see the vas deferens, right? So I'm pulling the peritoneum behind. So now you see sort of the hernial sac is completely separated, right? So it is a peritoneal covering, right? So it is completely separated from the wall, right? So now we want to reinforce the defect or the weakness in the wall, right? So to do that, one thing is we can approximate the weak area. The problem of approximating the weak area is in case if it is bigger, there's a lot of tension and the sutures will cut through. So as an alternative, we use a mesh.
So you prepare, so first we isolated the sac and then you separate the sac.
Yes.
And then that is not enough because the inherent weakness is there.
Yeah.
So you have to do something for the
Reinforcement.
Yes. And you said one can be tight approximation. But that is
that causes of tension. So the recurrence is high.
So this is tension-free repair.
This is a tension-free repair. We don't approximate it. We leave the defect like that, right? But we leave a mesh or a net, right? The mesh net is much bigger than that, right? So it is not just plugging. So we lay it over the weak area.
So how does it is it mechanically cover? Is it because of the strength of the mesh that it prevents?
No. Now even the lighter mesh are better. The mesh which has a sort of bigger pores are better. This just acts as a scaffold over which, as Madam explained, the fibrous tissue or collagen are laid down and they mature.
Here there will be what we call a foreign body reaction.
Yeah.
Right? Okay. So there is a interesting thing that happens here. This acts as a foreign body and it will cause a foreign body reaction. And at the same time, it will cause pro-inflammatory mediators, bringing in all those effectors I told you earlier about, like fibroblast growth pattern and also fibrosis and all that will take place. But it's a very interesting situation any of those things can cause problems. I don't know how often you see problems with measures. Because sometimes when the foreign body reaction is overwhelming, you can get the mesh being degraded and even being rejected. So probably the newer measures are less
more inert.
more inert and less
But
reactive.
if it is inert, it will not produce the expected fibroblast reaction.
That's why we need a balance.
I don't know how much you all use coated measures.
We don't use portal measures for these things.
Is it still like more research oriented? Because
No.
now they go
For other places, we use portal.
right. So the
There is
basis.
this intraperitoneal only measure there, where you can place on the peritoneum, so that the coated surface is facing the abdominal viscera, so it not come into contact with the mesh. Otherwise, it's attachment of the viscera and you only need to lose issue with this prosthetic method. So coated methods there are three types of laparoscopic hernia. One is the transabdominal peritoneal, this is the total extraperitoneal, the other one intraperitoneal only.
Can we just
For that, we use this coated media.
So the other thing they do now with coated measures is they use certain cell lines which will promote fibroblastic proliferation as well, like mesenchymal stem cells and all they go with it. Biological measures, yeah. So that is typical basic molecular pathology.
So this sometimes
When
we
you
see,
become a research surgeon, you can do that.
sometimes when we see when we do this, we see seroma. So that could be a reaction of excessive inflammatory response.
That is.
And the other thing is when the pore size is very small, these inflammatory cells can't go across the mesh. So they are the scavengers. Larger cells like macrophage can't go through it. So that is why we use sort of now porous measures, larger. They say usually 70 microns is the size now. Because it is not the strength of the mesh which is going to hold or strengthen the weakness.
With the fibroblastic reaction.
It is the fibroblastic reaction. Otherwise, you would have placed a plastic sheet here.
Steel.
That would have been better. So mesh just act as a scaffold. So if he has a collagen problem, smoking, mesh is not going to do well. So any collagen problem, collagen disorders, or anything which prevent collagen maturation, right? That's why infection, right? The chances of recurrence is high.
These spaces, can you tell the spaces he said intraperitoneal, preperitoneal, and can you tell the
Yeah, now one thing for medical students on this,
Yeah.
there is this myopectineal or this anatomy, where you have a deep direct space, the Hasselbalch triangle weakness, then the indirect ring and the femoral canal on. Now this is sort of it's a posterior approach to cover this. Now in open operations, all anterior approach, right? So this is a blanket coverage of all the areas. The medical student might be thinking where is that. So it covers, even though it's a direct where the defect is in the Hasselbalch triangle, it covers the indirect ring over that area, and covers the femoral canal, everything. Right? Okay. Right?
So you said intraperitoneal mesh and preperitoneal mesh.
Yes.
Which one is what you mean by intraperitoneal?
Now
space?
this is what Sumudu showed us was trans-abdominally. He has gone and he has made the space above the
That is outside the peritoneum. So that is
Yeah.
what space is that, the cavity?
Yeah, now he has exposed that muscular accumulating wall of that. So, and he has put this mesh, which is a polypropylene mesh, and which activates fibroblasts to lay down collagen, and then he doesn't want to keep it because the viscera can come and
It
get attacked. So he's covering the
Peritoneum
peritoneum. That is transabdominal pre-peritoneal.
So pre-peritoneal is
Approach.
actually outside the
Yes.
outside the peritoneal.
Outside, the mesh is placed outside. Now the same operation we can do without going through the peritoneal cavity from the skin, abdominal, muscular appendage, over that approach is over anterior to the peritoneum, right? Make a space, and there also we can use the same mesh. And another one is especially that's in ventral hernias. In hernias where we use there are large defects, right? There is a easy approach. We can place a mesh, but at the same time we don't want the viscera to come and get attacked. For that, the surface facing the bowels are coated with material which prevents this getting that is called intraperitoneal high form.
So to prevent one complication, that is sort of adherent of abdominal viscera to the mesh, we cover the peritoneum. Madam, how does it heal peritoneum? Now when we approximate peritoneum, is it healed with fibrosis?
Just the epithelial layer and grows and cover the epithelium.
No, there's no epithelial layer, no fibrosis or collagen.
Right. So this roughly conclude.
There
is some take home or homework as well. We told this doesn't cover hernia from A to Z. You have to understand this just to sort of highlight what it is. And we talked about laparoscopic mesh repair, but sort of go and read about. So what are the other modalities to treat hernias other than surgery? And what are the different types of surgeries to treat inguinal hernia? One thing is sort of should all inguinal hernias be repaired? Right? Read about it, you will find an answer for it. Right? We didn't discuss about clinical features, physical signs of hernia, read about it, right? Altogether, sort of what are the different types of hernia and different modalities. Okay. Any questions?
Okay.
And in the absence of the questions, I'd like to thank all the participants.
And we'll send a feedback form probably.
With all your busy schedules or
And always make time for surgery, no problem. There is a small presentation which I leave, which we covered, most of which has been covered today in our discussions. But it's all there if they want to have it. No, what we have spoken is all covered here.
We can just put it up. We can upload it again. We can.
Yeah,
what
they
they
can
want.
have it here.
And we expect sort of you to sort of email or
We send a feedback form.
here. If you think sort of this too long, tell us as well. What should be the more convenient time for you? Those things are also entertaining.
You all don't have any questions.
These are the
If it's left without approximation, it will be even then, I don't think there's an epithelium as such, but there's a mesopithelial layer.
there is
Probably
there is one question.
Yes.
So in a complicated hernia, as a house officer, until definitive surgery, how do we manage?
How do we manage? So you understand that sort of we need surgery, right? This is very good. And we need urgent surgery, right? So I think sort of you're asking about strangulated or obstructed hernia. Even irreducible hernia is a complicated hernia, right? But in obstructed hernia or strangulated hernia, it is an emergency. You have to do it as soon as possible. can't delay it. By the sequelae of that is perforation, peritonitis, death. Right? So it is a killer. So now with these patients, even obstructed or strangulated, there is a bowel obstruction. So they have distended abdomen, they may be having vomiting, so they have fluid and electrolyte deficiency.
Physical resuscitation is important.
Yeah. So before surgery, it is important to make him a suitable candidate for surgery. So mainly, it is not bleeding, they are not hypovolemic, but they may be dehydrated. So they have to start IV line, assess their level of hydration, correct hydrate, this thing. That doesn't mean sort of you have to delay surgery. So while getting the theater for surgery, you have to hydrate him, correct electrolytes. And one thing it is important now, this is very likely they have a higher chance of now there is a chance of opening into a contaminated vessel.
Also. Now, let's assume the patient is not fasting. Patient comes after with the obstructed hernia. Should you wait for 6 hours fasting?
No, because when patients fasting, we want patients to be fasting, expecting them to have an empty stomach. So then the risk of aspiration will be reduced. But this patient is unlikely to have an empty stomach even after fast for 12 hours. But and also delaying you're not going to achieve fasting state anyway. Empty stomach. Delaying is only make the problem worse. So we don't expect these patients to be fasting. We modify our anesthetic technique and proceed.
So that means sort of you don't have to fast these patients for 6 hours as in for routine case, right? Other thing, in addition to resuscitation, we start antibiotics empirically in this patient because it is likely to get into we are opening into a contaminated area. And during surgeries also, we are trying our level test to reduce contamination.
Can this patient be septic with this?
Yes.
Can we
Now, when the bowel is obstructed, the bowel wall is thin out and the gut translocation is very high. So even the intact bowel wall, there is bacteremia.
I think the problem they ask is now sometimes we have seen patients coming with obstructed and cellular hernias who keep ice. Is it important? And the second thing is sometimes some people when they come with obstructed
They
they
try to
reduce. Is that appropriate? And sometimes we see the foot end of the leg is also elevated.
Irreducible hernia, of course, raising the foot end, right, or trying to do other things are acceptable. But when it is strangulated or obstructed, I think one should not try to reduce it. If by chance, if he reduces, he's asking for problems because the things which you could have been done through the inguinal incision may need now laparotomy.
So is there importance? We make a difference keeping ice.
It will not sort of sink to a level to be reduced, and even the reduction is we don't want it.
You prefer to look at the bowel or whatever.
Yeah. We don't want to reduce it.
What about the person coming obstructed with the like acute abdominal obstruction, bowel obstruction, without a history of hernia? Isn't it important? I think we were taught, no, how important it is to examine the hernial orifices.
Especially the femoral hernia. Notorious. Even if you don't see a femoral hernia, the pain in the groin is big. And hernias we didn't tell sort of groin hernias are common among males. Even among females, inguinal hernias.
We can go on for days about hernia.
So we'll wind up and thank you very much for your participation.
And please send the feedbacks once we send you a form.